It's my pleasure to introduce our next speaker, Dr. Adam Sarkar. Dr. Sarkar was born in Calcutta, India, and raised in New York City. His name, as well as his interest in science and medicine, stem from his father, who was a biophysicist. In high school, Dr. Sarkar earned distinction as a nationally recognized Westinghouse Science Scholar. Dr. Sarkar then went on to earn his undergraduate degree from Brown University, where he spent his summers investigating viral oncology at various institutions, including the Ludwig Institute of Cancer Research in Switzerland, the Rockefeller University in New York City, and the University of Georgia. Dr. Sarkar then went on to earn both his MD and PhD degrees from the University of Miami School of Medicine, where his PhD dissertation had a focus on molecular neuroscience that culminated in the cloning and characterizing of neuropeptide receptors from the brain. Dr. Sarkar completed his neurosurgery residency at Mayo Clinic in Rochester, while also performing his postdoctoral work in single molecule mechanics, nanotechnology, and instrument design at Columbia University. Currently, Dr. Sarkar serves as the Director of Stereotactic Functional and Epilepsy Surgery for the Global Neurosciences Institute. He is the co-director of the Philadelphia Voice Tremor Center and holds rank of a professor for Drexel, University College of Medicine in the Department of Neurosurgery. Please welcome Dr. Sarkar. Today he will be talking about neuromodulation in the setting of epilepsy. Please feel free to type any questions you may have using the Q&A function throughout his talk so that we can address them at the end of his talk. Without further ado, here is Dr. Sarkar.
Well, thanks, Josh. Let's see. So first I share screen, correct?
Correct, yes.
And here we go, I think. All right. Does that show up for you?
It does. We can see it and we can hear you perfectly.
Okay, great. Well, Josh, it's good to see you in a jacket and tie. I think I've only seen you in scrubs, and you and your colleagues should be congratulated for putting this together. So I appreciate the opportunity to talk about neuromodulation in epilepsy. Like many of your prior two speakers, I think neuromodulation, whether it's for epilepsy or movement disorder, or as being alluded to for other things like neuropsychiatric afflictions, it's probably the most exciting thing that I do as a neurosurgeon. We certainly do a lot of things in neurosurgery, but I have to say that this, if you're an up-and-coming surgeon and you want to think about where the field is heading, being able to modulate the brain, I think, is as exciting as anything else. So let's see, how do I advance? Just to highlight what you said, Josh, that's the University of Miami. That's where I lived. That was 8 years worth of living on the beach and studying and working. And I have to say, that was a pretty wonderful situation. But as incredible as the scenery was here, when I went and did my residency at the Mayo Clinic, even though the weather was bleak and the cultural sort of aspects of that were quite different from Miami, that was probably the most incredible setting for medical care and education that I could ever imagine. So I was really fortunate to have that opportunity. You alluded to the fact that I was at Columbia University. This was a picture outside of where we lived. We didn't go for the free parking. We went for the PhD postdoctoral fellowship opportunities. So when I'm not doing any of these things like studying, physicianing, research, I've got these 3 random particles that I'm accountable for. And it shows that even if you're a neurosurgeon, regardless of the let's say the stressors on the job, you still actually can have kids that still enjoy your company and like you. When I'm not doing any of that and I have time to myself, I go climbing. This picture is from Peru. Let's start talking about neurosurgery, and let's start talking about the opportunity that neurosurgery affords us. I think it's a real incredible window back on the past of humanity. Ever since the Neolithic, and when people grew together as cultures, no longer hunter-gatherers, we've been doing neurosurgery for almost as long as we've had communities of humans. And I think that it's pretty incredible and important for anyone that's going into neurosurgery to realize that incredible legacy. Obviously, it wasn't the same sort of venture that it is today, but I think it's something to be incredibly proud of. Here is this skull from Europe that shows that there were two craniotomy sites here. And we know that this patient probably survived, who knows how long, but there was bony healing. So it means that who knows why they did it or what happened, but there was rudimentary surgery that was being done on the calvarium over 7,000 years ago. And then if you peek back 5,000 years ago, some of the earliest texts, for instance, the Edwin Smith Papyrus, which is really a surgical papyrus, and it really predominates with neurosurgical complications, head wounds, spine injuries, and probably it has to do with Egyptian, pyramid building or war injuries. But fundamentally, the most important thing was it codified the diagnosis of surgical problems, and it said whether they should be treated or not. And most incredibly, this was the first time in this hieroglyphic here that the glyph for brain was ever written down and used. So I think that for all of us neuroscientists, neurobiology geeks, that's a pretty important landmark. Just to show you a little bit of what the Edwin Smith Papyrus has to say, and I know that this doesn't have to do with functional neurosurgery, but it does have to do with our history of how we got here. Here's the way that 5,000 years ago, you can imagine that most of medicine was magic or some sort of contortion. And here you have in the Edwin Smith Papyrus something that says concerning the displacement of a vertebra. And what was that? Well, they make an examination and they say that this person has his neck and he can't turn it. And so if any of you are really savvy with spine, you'll realize quite quickly that that's a jumped facet. And incredibly, over here in the diagnosis, it says that here's something with the displacement of the neck, and it also says that here's an ailment which I will treat. And I think that's really important because not only is it just using, we've sort of left magic and we're talking about what we can treat and what we can't treat. Obviously, the treatments with binding fresh meat and things like that are certainly not something that we can hold a whole lot of platitudes towards, but I think that it's important to see this long history of humanity in neurosurgery. Let's see, need to go to the next slide. And equally, primitive peoples or earlier people, because this is from the Andes and they weren't primitive, but people had, once they started being able to forge things into things other than from rocks, but into copper, for instance, here, they were making trephines. We'll never ever, and you'll never see this in the OR, but this is how these kind of trephine holes were made. I think it's pretty incredible that these patients survived because anyone that's really, really keen on seeing where this is really at the torcula. This is where just about every major, well, not just about, this is where every major sinus meets. And the blood that you will let from one slip of that trephine would be devastating. So the fact that people survived, I think, is incredible. And it's a tribute to the legacy that we bear. Now, trephines and Edwin Smith papyruses aside, I think most of us consider, and when you ask people, what do neurosurgeons do, and what do surgeons do in general, they think of us as structural technicians. For instance, here's a very, very small colloid cyst that's sitting right here at the foramen of Monroe. And intraoperatively, we can go intrahemispherically, take it out, and the postoperative scan looks like it wasn't even, like we weren't even there. Equally, you can have much, much smaller, much larger pathology, like this sphenoid wing meningioma, And you can take that out of a patient en bloc, and you can actually have a patient walk out of the hospital, which I think is pretty darn incredible. Equally with the spine, again, like I said, most of us most people think of neurosurgeons or surgeons in general as structural technicians. And here's a C6-7 disc herniation. It's kind of outlined over here. You can see it here on the sagittal. Intraoperatively, we can go in, we can take out the disc. And in this situation, my solution here was a disc arthroplasty. And again, just structurally taking away something that was impinging on a nerve root element and then fixing it in that manner. Equally over here, here's the spontaneous epidural abscess or spontaneous epidural hematoma that developed in this 17-year-old that was rapidly losing neurologic function bilaterally. This is a MRI scan in this middle panel that shows, I've sort of false colored it and showed the edema that was running up and down the cervicothoracic cord. And again, taking him to the operating room in relieving the hematoma allowed and afforded him a opportunity to have full neurologic recovery. So that's what we do a lot of. And even things that are sort of you would think, wow, how are you going to fix that? This is a kid with Cripple file. He is a 11-year-old expert black belt in judo. And one day when he was in his dojo, his arms went numb, and you can see that C2 is basically impinging on the brainstem. Over here on the sagittal scan, you can see C2 is right in the middle of the foramen magnum, someplace it shouldn't be. And again, as structural surgeons and technicians, we can realign things, put C2 back into a more anatomic alignment, and help folks. Intracranially, looking at something like a glioblastoma, which looks like a confined lesion, and it looks like it sits right here, and it looks like post-operatively we've taken it out. We know that there are more nuances to that. So again, even though this is a structural lesion, and we take it out, we know that there are still problems. And if any of you are not aware of what GBMs are, here's, for instance, a video of that patient. We used to, when I was at Ohio State University, we would collect cells from our patients, and we still do that where I am today. But this is just a brief video that shows you that all this crawling around on this Petri dish is what's happening in somebody's brain. So that's probably one really good example of why, or a very, very good illustration of why GBMs are not, in the end, surgical diseases. It's because they are not discrete and definitive, but they are diffuse. So now let's go back to epilepsy, and let's go back to history. And if any of you can see this well enough in the background, this is a cuneiform tablet, and this is from Babylon. And this is over 2,500 years old. And ancient cultures understood neurological diseases. And the reason why they understood many neurological diseases is because the manifestations were obvious. You know, if you had high blood pressure or if you had diabetes, nobody knew what your A1C was or what your diastolic pressure was. But if you had a stroke and you couldn't use an arm or a leg, it was pretty obvious. If you had a seizure and you were shaking, it was pretty obvious. So I think that's why neurological disease, because it has such a direct physiologic manifestation, is why it's fascinated people throughout, like I said, ever since the Neolithic and ever since we've been as communities. Here, not as, say, nuanced as what the Egyptians were, but here I'd like to point out to you something of epilepsy. And when they say temporal aspects of epilepsy, they don't mean temporal lobe, they mean just the time. And for instance, it's saying if an epilepsy falls upon a person, that it's a possession by a demon or a departed spirit. You know, clearly not the case, but they felt that there was a cause for this. And within that cause, it was very interesting that said that if this demon falls upon this person and it happens once or he can cry out, that his life will be spared. And they're talking about, focal epilepsy. But over here, if it says it's possessing him 2 or 3 times during the day and the condition is chronic, well, that's fundamentally status. And they're saying that he will die in his state of epilepsy. So I think it's really interesting to know that way long ago, millennia ago, there was this notion of epilepsy and this notion of what was, say, survivable and what was not. Fundamentally, if you think about anything in the brain, you have to think that neurons are the base unit and the currency of the brain is electricity. And a seizure, as I've pointed out here, is a temporary disruption in brain function. And the brain typically functions in a desynchronized manner. And here there's hypersynchronicity, and you have this abnormal discharge from neurons, and that's why you have seizures. The neurons can be focally discharged, they can be more globally discharged, say if the source of epilepsy may be originating in the thalamus or some other more global center, but nevertheless, it is this hypersynchronous excessive discharge. That's the bottom line. What causes epilepsy? Well, if we knew, as was pointed out, say for dystonia, where there's a DYT1 gene, if we knew that, it would be a little bit easier to understand these channelopathies, or these aberrancies with sodium or potassium channels or chloride channels. It's not really clear. We do know that most of epilepsy tends to be idiopathic. There's nothing that we can truly ascribe to as why the epilepsy is being manifest. But we know that there are some things that will predispose you to epilepsy, such as prematurity, brain infections, brain tumors, strokes, or again, family history, even though the genetics might be less than obvious. So I don't think that anyone at this point in their training, I think it's very important to know that there are terms for epilepsy, and there's an organization called the International League Against Epilepsy, and they have a seizure classification scale, and I've put that up here. There were some old terms like, say, grand mal, and now it's just considered generalized seizures. I don't think you need to necessarily know that. You should know what the difference is between focal epilepsy and generalized epilepsy, but just keep that in mind. Fundamentally, if we're going to talk about epilepsy, and that's exactly what we're here to talk about, I think there are a couple of terms that you need to know. One, you need to know, just like, say, with everything, when you're on your internal medicine rotation and somebody's wheezing, everything that wheezes is not asthma, just like everything that seizes is not epilepsy. Okay, so keep that in mind. And then when you think that you do have an epileptiform disorder, there are those breaks between what is a partial seizure, and here in this cartoon showing you sort of this one focal area in the brain that has a abnormality, versus what is a generalized seizure, which is showing you that there's bihemispheric or much greater involvement. All right, and again, whether you're understanding whether they're simple, complex, tonic-clonic, atonic, absence, I think that that's important for those of you that want to become nuanced with this, but fundamentally doesn't matter at this point in time. I think that epilepsy represents one of those real conundrums, at least for me as a surgeon. Many times, we'll see a brain tumor and the answer is take it out. We'll see a disc herniation that's creating myelopathy, and we'll operate on it. We'll see a fracture dislocation, and we'll operate on that. Folks who succumb to epilepsy are obviously being given medication as a first-line treatment. It is baffling to me to think that it takes on average about 18 years for an epileptic patient to make it to a tertiary or quaternary care setting where their seizures can really be evaluated. And we know that just adding one drug after another doesn't necessarily make life better. It's compelling to think that, oh my gosh, rather than having brain surgery, I'd rather take a medication. But if the medications aren't going to help, why would you want to have more seizures? Because I can guarantee you more seizures are not more better. This article was always really instrumental to me from 20 years ago with Kwan and Brody. These are two neurologists, epileptologists that basically let us know and gave us the information that says if you haven't had any kind of meaningful relief from your seizures after 2 medications, any further drug therapy is likely going to just simply fail. And I think that that's a really important thing. Just trying one drug after another drug after another drug just perpetuates this problem. And then, like I said, 18 years later, maybe you make it to an epileptologist who has a surgical mindedness and brings you to his surgical colleagues. It's almost as if your car has a flat tire and you say, yeah, I think I'll check this out in about 2 decades. It's ridiculous. And we do know there are very few randomized controls in neurosurgery. There are some nice ones in movement disorder, as were alluded to earlier. And here's a great one from Dr. Wiebe and his group for the effectiveness and efficiency of surgery for temporal lobe epilepsy in particular. And really the conclusion was that temporal lobe epilepsy surgery is superior to prolonged medical therapy. And I think that that is great for us as surgeons. But again, I think the challenge is making our population of patients understand that this is what should be enacted on them. Movement disorder patients, epilepsy patients, functional patients in general, aside from, say, pain, tend to come to us through secondary routes, usually through a neurologist that's been seeing somebody for movement disorder, usually through an epileptologist that's been seeing somebody for their seizures. So we're not seeing these patients right away. And so our ability to engage them in a surgical discussion is usually several years or even a decade down the road when they're already sort of conditioned to thinking that, oh my gosh, I don't need surgery for this, or I don't even know that there was surgery for this. So that's, I think, one of the challenges for much of our movement population and our epilepsy population. Usually, patients will come to us and say that, my goodness, I didn't even know that I had this solution. Patients are really, they're seeking it, but they're not getting good information because many of their primary providers are just reticent about sending patients to neurosurgeons and thinking about getting holes drilled in their heads. And I understand the apprehension, but if we can do things safely, I think it's our onus to bring it onto the population at large to show them that neurosurgery is something that's safe and effective. So let's go back to epilepsy. Increased CNS excitability. It doesn't matter whether you're thinking about this as a depolarization or increased excitatory input or how it is, but it's just increased CNS excitability. It could be because there's a lack of inhibitory or there's a additive effect of excitatory. It just means that things are out of balance. And again, there's that notion of focality with your seizures to global or generalized seizures. Typically, we think of that originating in the thalamus with its widely distributive networks. This is a person that we learned a lot from. And this is a person that was not a physician, not a neurologist, but this is somebody designated HM, Henry Moilson. He either, I think he unfortunately met this guy, Dr. Scoville, and underwent bitemporal lobectomies. And Henry, or HM as he was known for so many years, was absolutely unable, and this was for epilepsy. They felt that he had temporal lobe epilepsy. They felt that it was in one lobe. They took that out. It didn't help. They took out the other lobe. And lo and behold, my goodness, he had no ability to form new memories. He was able to actually subtly, and this is probably too much in the weeds, have the ability to gain procedural memory, but no other kind of memories were able to be codified by him. And here you can see in these reconstructions of these bitemporal lobectomies, and over here you can, even if you don't know much about where epilepsy lives, this would have been the hippocampus, and this has been taken out in HM. I think the most important thing about this not as a reflection of carelessness, because I don't think that the notion of trying to treat Henry was careless. I think it's just a reflection of understanding of what we did and what we shouldn't do anymore. So nobody would ever suggest bilateral temporal lobectomies, because it would potentially take away seizures, but it would also leave a patient devastated. And I think that that was the most important thing we learned from HM. You'll have to get savvy if you're talking about epilepsy to talk the talk. And you're going to need to know what the neurologists are referring to. And I'm not even going to get close to trying to explain this, aside from just I'd like you guys to see that even numbers are right-sided problems and odd numbers are left-sided problems. So right there, you probably know more than anyone that's starting their fellowship in epilepsy. So just keep that in mind. You know, nobody, this is not epilepsy. This is DBS. And I know that everyone loves showing these videos, and I really like them too, because we see patients that are awake. And for me, the most important thing about this video is not what we're doing here, but the fact that we're using electricity via, in this situation, DBS, to help this person's essential tremor. And as we move on in this talk, you'll see how we use electricity, whether it's DBS or whether it's something called responsive nerve stimulation, how we're able to gain control of something that you would have thought that we'd have no way of being able to gain control. So this is not epilepsy. This is not everything that shakes is not epilepsy. This is a movement disorder. This was essential tremor, and this is being treated with electricity. And that's the whole notion of neuromodulation. So how do we get there? Well, we get there through stereotaxy. And stereotaxy just simply means that we're using fixed reference coordinates, much like, say, this depiction here. This is a UNESCO site in Jaipur, India, that was set up for stereotaxy to look at astronomical events, to look at stars, to track the moon, to track the planets. Well, we use stereotaxy in the OR, as many of you know, to look backwards, to look into the brain. And so we create fixed references, and then we can use those fixed references to then navigate anywhere in that three-dimensional space of the brain. The first device that was stereotactic was this Horsley-Clark device, but this was not used in people. This was used in monkeys. And this was the first time where a fixation system was used to then put the CNS, in this situation of a monkey, into a stereotactic Cartesian coordinate system, so they could precisely and reliably identify areas, but also for what they did was create lesions and see what the effects of those lesions were. It took several decades later in Philadelphia. I'm in Philadelphia, and I'm very proud to be in Philadelphia, because Philadelphia really is the birthplace of human stereotaxy. And that was generated at Temple University. That's one of our institutions in town, by Spiegel and Weissis, these guys here. They created this frame, which looks monstrous, and it probably was, in order to, again, put the human anatomic coordinates of the CNS into a system that could reliably and repeatedly be interrogated. Back then, there was no MRI, there was no CT scan, so things such as outlining the ventricular system with air or using relatively commonly well-known landmarks such as the pineal gland here were utilized to have a rudimentary map of the brain. I can't ever imagine thinking about doing surgery this way, and I can't imagine the stress that these guys must have been under when they were just simply using these coordinates. Yeah, I mean, it's a tribute to their talents. Today, I think you've seen examples of what modern frames look like. This is a Lexel frame, for instance. Here you can see there's an electrode that terminates right here in these reticulars, right at the center point of the target. I don't tend to use that. I tend to use something else, which I'll show you. But stereotaxy is just simply that, using a rigid point of fixation to understand other points. Like, for instance, this idiot was using a nail gun on a job site. These, I don't know if they're called nails or if they're called staples, but these 6-inch staples are fundamentally pointing towards all his deep nuclei. So for any stereotactic surgeon, that's one way of doing it, but not the way that I would ever recommend anyone to do it. Stereotactic surgery really, I think, had its foundations not only with clinicians, but also with somebody like Arthur C. Clarke, who, if any of you know 2001 Space Odyssey, he wrote over 75 years ago in this thing, Wireless World, where he talked about geosynchronous satellites in order to, with 3 different satellites, you could pinpoint the location of any spot on Earth. And that's actually true. If you have a 3-dimensional object and you have 3 fixed points of reference, you can then triangulate to any other point. I use bone fiducials. It doesn't matter. There are many different ways to skin this stereotactic cat, but that's what I just tend to use. When we use bone fiducials, we can use those fiducials to really highly localize very small areas and fix them. We use those bone fiducials because I think it shows you a reflection of what we used to do. Here's, for instance, a surgery that I think for me probably might have been maybe only 8 years ago, but still it was, it's rather dramatic. It's hard for you to necessarily understand everything, but this is basically the frontal lobe right here. This is the temporal lobe right here. Here's the floor. We're going all the way back to the occiput and getting to the parietal lobe here. And we're literally opening up half of somebody's head to put in all these grid electrodes and even some depth electrodes down here to try to map where their seizures are coming from. It's incredibly painful on the patients. They hate it. They feel miserable. There are CSF leaks. There's risks for infection. And it really is, I have to say, somewhat barbaric. That doesn't mean that we don't and haven't found solutions, and that also doesn't mean that grids and strip electrodes are something to be avoided. But when you're doing a large survey, it's probably something that you want to do something more nuanced for, and I'll show you that. Here's a coronal section of the brain, and this pink area here is the hippocampus. And you've got the uncus over here, or the amygdala here, amygdala or nuclear up here as well. And this is deep, and this is not necessarily easily accessible as, say, cortical tissue. And if there's anything that's been more of a challenge, it was being a PGY2 on an epilepsy surgery service in trying to understand the nuances of 3-dimensional anatomy that kept on turning on itself in order to figure out what's going on in epilepsy surgery. And structures that are way critical, like the optic tract and the mesencephalon, are so close to where you are. In addition to just going into the deep nuclei, you'd have to be really lost to get there. But nevertheless, all those critical structures are so close that I think it really takes a long time, a lot of exploring through atlases and understanding where you are when you're doing epilepsy surgery, because much of epilepsy surgery is temporal lobe surgery. There is temporal lobe surgery and extratemporal surgery. Typically, temporal lobe surgery has better outcomes. Extratemporal surgery tends to drop down in our effectiveness, except for these days now that we have really wonderful neuromodulation devices, and I'll get into that. I think if you're an epilepsy surgeon, you really have to have a really good understanding of brain and brain anatomy. And I don't mean that in a facetious way. Obviously, vascular surgeons need to, obviously, tumor surgeons need to, but we have to understand the brain in a way where it's oftentimes upside down from how we're normally thinking about the brain or what we're looking at. And you have to come to grips with terms such as, the collateral sulcus and the parahippocampal sulcus. You have to know what the various gyri are. You have to know where the limitations are of the amygdala and the hippocampus, because in the next few structures that you'll get into will be the brainstem, and that would be making for an awful day. Equally, you have to be quite well aware of the vascular anatomy that surrounds here, and that's usually the PCA, which is a structure that you'll see if you're doing epilepsy surgery. Again, I think it's worth knowing, maybe not entirely committing to memory, but just having these terms in your head and remembering that, you go from the infratemporal gyrus to the fusiform gyrus to the parahippocampal gyrus. Those, I think, structures are important to know. You should know that there's, and again, this is temporal lobe epilepsy. There's a collateral sulcus, which for epilepsy surgeon is really a gateway or a highway for knowing where we are and where we resect to. Here's a set of pictures from a book from Fred Meyer. Dr. Meyer was just on staff at the Mayo Clinic at that point in time. He was formerly the chair, and now I think he might even be the dean of the medical school at Mayo. And so epilepsy surgery was something we did a lot with Dr. Meyer. And it looks like it's easy, just simply reflect the scalp, open the calvarium, open the dura, get down to the hippocampus by going through the neocortex, finding the amygdala hippocampus, finding basically the interlimbic gyrus, separating that off, taking out Amon's horns vessels off of the PCA, and you're done. In principle, it's a beautiful, elegant, oftentimes literally bloodless surgery, but it's one that takes years and years and years of practice. At least that's what I think. This is the way that my epilepsy practice has evolved too. And this, I think, is more in kin and in keeping with principles of neuromodulation. So for instance, this patient here has a bunch of bone screw fiducials. You can see there's a fiducial here, a fiducial here, a fiducial here. There's probably a couple fiducials here. And we make this customized frame based on these fiducials to create trajectories to interrogate areas to try to figure out where is this patient's epilepsy. You can see over here on this AP that we've got both the right and the left side of the brain being covered, and you can't ever imagine doing such a big set of uncoverings if we were going to do that with a craniotomy and putting grids and strips on. Here's a really beautiful, elegant way of covering the brain, covering the frontal lobes, covering some of the parietal lobe, covering the deep structures in the hippocampus, and even lateral structures in the temporal lobe through these little pinpoint electrodes that patients tolerate exceptionally well. We've easily had patients in our EMUs for up to 4 to 6 weeks if they've needed to be while we're trying to wait for their seizure disorders to make themselves present to us. Electrodes, like for instance, here's a younger patient who had a glial neural tumor. And the whole notion was he came to attention because he was seizing. And he was actually having focal motor seizures. And it's probably not too surprising that he was having focal motor seizures because this is basically his somatosensory and his motor cortex up here. And so it was really important and critical for us to have a good sense of understanding if we put electrodes in that were ringing this area of his tumor anteriorly, how much space did we have before we got into the somatosensory cortex? And posteriorly, was there anything eloquent back there? We were able to put these electrodes in, we were able to document the seizures, which wasn't a surprise, and we're able to use not only the electrodes to record, but also to stimulate and try to map, not try, we did, to map this patient to understand what our safe resection boundaries would be. And you can see we understood that we had just basically a wisp of a gyrus anterior to us in order to afford this resection. And the patient was able to become seizure-free and tumor-free by using the principles of neuromodulation. I tend to do a lot of measuring. I feel, and I think many surgical colleagues will agree, we often measure twice and cut once. So even if my neurology colleagues will say, oh my gosh, this looks like a clear-cut, slam dunk case of mesial temporal sclerosis, I just want you to take it out, I will typically put depth electrodes in, and here you can see this is a 12 contact electrode, and I will put it not because I doubt my neurologists, but I want to know to what extent do I have to perform a resection? Do I have to perform a resection that focuses on the anterior aspect or say the first 4 contacts? For me, I find it very gratifying to understand and say, okay, if I get to contact number 6, I know I've taken out all the abnormal discharging. That to me makes me feel good. It's almost like if you're to have a patient that has a very classic L5 radiculopathy, you'd never not get an MRI scan and just say, you know what, I guess we're just going to go to the OR and just explore the L4-5 space and see. And if that's not right, well, maybe we'll go down to the L5S1 space. So I think measuring and knowing and understanding and localizing is absolutely critical. And that's what neuromodulation gives us. Here you can see we've got the hippocampus in focus. Here's some choroids, so we're in the ventricle. And you can see in this situation, 1, 2, 3, 4, 5, 6 electrical contacts were exposed because we knew that the focus, the majority of the epilepsy was coming from the first 5 contacts. And so I took a little bit more just to be sure. And lo and behold, indeed, this patient had an excellent outcome. I think that when we don't measure as much, we don't have as objective criteria, and then our outcomes can waver. Here's where I'll go to the real heart of neuromodulation. We talked about the Egyptians in the beginning, and we talked about the fact that they understood what the brain was and had hieroglyphics for the brain. We talked about the Edwin Smith Papyrus, which was an Egyptian document. The Egyptians understood a lot. And the Egyptians were among the first to understand that you could use electricity for medical purposes. And I'm sure this was an accident. Somebody was grabbing this Nile catfish and its stingers caused a discharge and it created a painful sensation. But it must have been something where somebody who was arthritic was catching catfish, and after they got stung, their pain was relieved. And so they even used this as therapy for somebody with painful arthritis. We don't use catfish in the OR, at least nobody that I know does. But what we do is use what I think is some of the most incredible technology. Now, this is from NeuroPace, and this is a what we call a responsive neural stimulator, or RNS system. In this patient right here, if you're understanding left and right, this is the left side of their head. And this is, just take my word for it, or on this image here, this overlies, we were able to figure out through, I think it was strips and grids in this situation, we were able to figure out that this patient's epilepsy was centered on their motor cortex. It's the left side of the brain, so all of you know that that means the right side will be affected. So even if we could tell them that, oh my gosh, we'll just resect the area of your right motor cortex or your left motor cortex and your seizures will go away, I don't think anyone would volunteer to exchange epilepsy for plegia, even if it's in one limb, but be it the dominant limb. So what do you do here? Do you just put people on medication? Absolutely not. This is a remarkable device that can not only sense electrical activity and learn seizure activity, and then it can actually discharge to stop the seizures before they occur. Some people call it a brain pacemaker. I think that's sort of belittling what it does. It's a highly sophisticated device that lives implanted in the skull. It's got a microprocessor here, it's got a battery here, and it senses and delivers therapy, which is really incredible. Here's a situation where we were again using bone fiducials, which we always do, and we were putting electrodes in, and over here it's probably a little bit hard for you to tell, but these electrodes, two electrodes are going down the long axis from the occiput towards the front of the head, in through the hippocampus and into the amygdala, and these other two electrodes, much higher up situated, are going down the long axis into the temporal lobes. And what we're trying to do is figure out which temporal lobe had a problem and which amygdala hippocampus had a problem. Well, it turns out that the problems were coming in this patient from his left hippocampus and his left temporal neocortex, not his left insula, which some of our epilepsy colleagues thought it was coming from. And it was compelling because there were some imaging findings that would have led us to believe that. So what's to do here? Is that like, oh, wow, awesome, let's take this out? No, the problem was we were getting seizures from these temporal lobe structures, but we were also getting seizures from these neocortical structures. And the neocortical structures were more posterior, and many of you will know that put his language at risk. So not being able to resect, over here what we did was we placed again, a NeuroPace. This time these aren't strip electrodes, these are depth electrodes, and we put one. We replaced this recording electrode for a NeuroPace depth electrode in the hippocampus, and another one in that lateral neocortex. And we've been very fortunate to create a seizure-free patient, which is really, really incredible and really, really rewarding. And if you think about it, you know, in many of our brain tumor patients, unfortunately, they will recur. In many of our spine patients, their backaches and their ailments will recur. Here's a way of providing unbelievable remedy to somebody and giving them back their lives. Here's a little bit of what the NeuroPace looks like. You are literally harboring this walking, talking EEG device that learns your epileptiform behavior and then will deliver a therapy when it senses that. And for me, I think that this is really incredible. This is what was being alluded to before about closed loop technology. We're not just stimulating all the time, we're recording and listening all the time, or much of the time, but stimulating when we need it. So this is really, I think, again, the future of neurosurgery. The future of neurosurgery is really just that. It's understanding the CNS, understanding what areas are having, say, abnormal discharges, and figuring out how to correct those anomalies. And I think with the brain in the bottle, that basically brings me to the conclusion of what I want to say, and I'm more than happy to take any questions.
Excellent. Thank you so much, Dr. Sarkar. I think we all learned a lot, not just about epilepsy and how it's treated, but a lot of the history that goes into neurosurgery. And it's so cool to hear about these closed loop devices as well. So to start off, we have a question from Lana. She says, you briefly mentioned the problem with epilepsy being overexcitation, whether excessive excitation or lack of inhibition. There have been some interesting developments in using inhibitory cell transplantation to treat epilepsy, to enhance inhibition in hopes of bringing a balance to the EI ratio. What are your thoughts on using cell transplants compared to electrical neuromodulation, with the latter being a more focal treatment?
Sure, I think that's everyone always comes back to cells, whether they're stem cells or not. And then whenever you say stem cells, and you always list things like Alzheimer's, Parkinson's, stroke. I would say that we have such a nascent understanding of cellular technology. Remember, the cells that you're putting in are going into an area that they never knew. The brain is unique. Cells migrate. And when they migrate in that early formation and they're coming out of the subventricular zone, they have signals like I'm making it up, but sonic hedgehog and other things that are taking them to places. Connectivity in the brain is absolutely important. And I don't know, and that's one of the downsides to cell therapy for, say, movement disorder. How do you make all those connections, and how do you prevent aberrant connections from being created so you don't have untoward side effects? Right now, I think our notion and our abilities to understand implant therapies for biologics is right now, or cellular biologics is limited. Doesn't mean that it shouldn't happen, but I think that right now, the real excitement that I see are these neuromodulation devices.
Great. And then we also have a follow-up from Lana. What are your thoughts on combining these treatments, especially when thinking of training the transplanted cells with electrical stimulation?
Yeah, so again, wherever she is, they must be doing that. And I think it's exciting, but I have thought that it would be interesting and exciting to have these systems that can also deliver medications. So not necessarily cells, but to deliver medications as well. Because as we all know, neuromodulation, we never tell our patients, oh, you're going to be drug-free. You're going to be with surgery plus your medication, hopefully symptom-free. And so I think an exciting area here is to monitor. That's what the closed loop gives us. And to think about future alternatives for delivering therapeutics like medications through these catheters, because we're putting them in places that are quite specific. So I would still say that I'm not a naysayer on cell therapy, but I would not say that it's something that's ready for prime time.
Okay, and since we have a little extra time, I typed up a couple questions, and I think one of them relates actually to what you were just discussing. So is stimulation combined with medications in patients, which it seems that it is, and do these have a synergistic effect or interfere with one another?
They don't interfere with one another. The only time they interfere with one another is, say, in one of the movement disorder patients. If you have somebody who has Parkinson's and you've only implanted one side, and you're taking care of their tremors, for instance, on one side with electricity, the other side that's stiff is getting medication, it can create imbalances on how to handle that. But if you have bilaterally implanted patients, generally what we say are the goal of our therapeutics, because remember, medications are neuromodulatory. It's not like they're just sort of not doing anything, they're modulating the neurons. What we think of as neuromodulatory are not medications, but we think we're going to use electricity because it is that currency of the CNS. So it's absolutely wonderful to use both. And I never tell my patients that they're going to be drug-free, but we're just going to say that their symptoms will be way better, whether it's my Parkinson's patients, movement disorder patients, OCD patients, or epilepsy patients.
So we talked a little bit about sort of the focality of stimulation, and there are certainly focal seizures, but also generalized seizures, as you discussed in the beginning of your talk. So given the focality of stimulation, will pinpointing the initiation point of an epileptic event and stimulating it be enough to prevent a generalized non-focal seizure?
No, you just answered your question. You can't. So we had an implant about 2 months ago where we implanted into the anterior nucleus of the thalamus, which is a very robust multi-system relay in the thalamus. And so when you have more generalized seizures, you might not be able to record them from the thalamus, but you would be able to record them everywhere cortically, and then you can come up with a treatment plan that would then allow you to go into a focal spot like the anterior nucleus of the thalamus and deliver stimulation.
How accurate is the NeuroPace detection of seizure activity in the closed loop system? And does it ever erroneously activate during normal activity?
Yeah, I don't think I have that information because we would only know if we were both concurrently measuring with NeuroPace and a secondary device. So if somebody had electrodes in that were placed by me and the NeuroPace electrodes, we could compare them side by side. But usually you get your depth electrodes, they swap out, you get your NeuroPace electrodes. So all we can say is based on clinical efficacy. But again, it also depends. The right patient with the right operation does amazing, and the wrong patient with the wrong operation will never find relief.
Excellent. And then one last question. So you discussed sort of the divide that exists between patients seeing primary care providers and then eventually getting referred to neurosurgeons. How do you go about having these discussions with patients about getting more invasive interventions if you think that might be the right course?
Yeah, I think that is really the impediment. For instance, if you're a parent, do you want to bring your teenager to a surgeon? Probably not. But if you have the right team, then that's where that matters, where you have the neurologist saying, well, these seizures are not really doing any good. We've got to figure out something. The thing is that much of movement disorder and even epilepsy gets handled by primary care practitioners who don't interact with us much, and their sense of boding on sending their patients off to neurosurgeons, I think, tends to be high. And many of our patients actually find through support groups, they'll find that, my gosh, my cousin, my friend, my whoever had an operation. Why can't I have that? And I usually say, well, you can. So it's still a challenge. And I think it was alluded to earlier. You know, we had a very dark past with psychosurgery. And I think people still think of neurosurgery with trepidation. Somehow they'll jump on a table and have spine surgery, but brain surgery tends to be somewhat off-putting to folks, even though that's where we can do the most for folks and give them back the most quality of life, I feel.
All right, and it looks like we do have one more question coming in just now from Drexel. Thank you, Drexel. He says, thank you for providing the excellent presentation. Can you comment on the possibility of using DBS or a similar modality to inhibit an epileptic event before it occurs?
Yeah, that's what the NeuroPace is. So NeuroPace is kind of like a more sophisticated DBS. In my mind, the DBS manufacturers like Medtronic and Boston Scientific will probably say otherwise, but the beauty of NeuroPace is it's closed loop. It understands the seizure semiology, or it trains itself to understand that, and then it delivers something to stop the seizures. So that's exactly what NeuroPace is doing.
Excellent. So I think that about wraps it up for this talk. Thank you so much, Dr. Sarkar, for again covering all the topics that you did, including epilepsy. And from here, I will leave it to Josh to introduce our next speaker, who unfortunately won't be able to join us live today. Go ahead and take it away, Josh.
Thanks, guys.
Right. Thank you, Dr. Sarkar, for the incredible talk.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.